Okay, while we've got it, I'm going to hand over to the lovely Claudine Clark.
Wow, that was an effort and a half.
Yeah.
Okay, let's just do.
Yeah,
Nice.
perfect.
Hang on a
Nice.
minute.
Hooray.
Right. Okay, we good to go?
Yes.
Oh, God. Okay, right. So thank you to the CHAP team for the invitation to present today. For those of you who don't know me, my name is Claudine Clark, and I'm the cardiovascular nurse consultant here at ICCNet, the Integrated Cardiovascular Clinical Network. And I manage the Country Access to Cardiac Health, or CACH program. I'm here to speak about the delivery of outpatient cardiac rehab using a GP hybrid model, or using a GP hybrid program within the CACH telephone program model. How am I looking in here?
Yeah.
I have the great privilege of working here at ICCNet, and it goes without saying that we are a team at ICCNet, and it is through our collaborative teamwork that makes what we do possible. So I acknowledge them today, along with the GPs, practice nurses, and our amazing patients involved with the program. ICCNet also gratefully acknowledges that the service we provide is supported by funding from Country SA Primary Health Network through the Australian Government's PHN program. Next slide. So this is just to give, I mean, this is really country people we're talking to, isn't it?
Yeah.
So you know the scope. This is a presentation I did on a national scale. So I just wanted to give them a scope of what Country SA consists of by showing them the red dot on the map marking metropolitan Adelaide, and that we in Country service all the other rural areas around that dot, shown on the right of screen. And it was really just to highlight that our scope is far and wide, and it encompasses a huge expanse of land, as you would all know. Next slide, please.
Oh, just when you turn on.
Oh, righto.
Yeah.
So for those of you who don't know what CACH is all about, in 2007 and 8, the statewide cardiology clinical network analysed cardiac rehab in South Australia and identified several gaps in service delivery, resulting in the formation of the cardiac rehab model of care for South Australia. Now, in partnership with Country South Medicare Local, Country Health SA Local Health Network developed the Country Access to Cardiac Health, CACH, a CACH project to address strategies within this model of care. And in that time, the CACH project achieved the implementation of a comprehensive database, as shown on this slide and many of us use, that records all cardiac rehab visits across Country SA through the telephone and face-to-face programs. It also achieved the utilisation of the referral database by all metropolitan public and private cardiac rehab providers, and it enabled all South Australian cardiac rehab referrals to be sent through to our central referral office. So it's streamlined everything basically. The CACH program has implemented a number of strategies and standardised tools to assist in the provision of phase 2 cardiac rehab to a greater number of residents to country South Australia, or in country South Australia. And it was established to increase the uptake of cardiac rehab in regional South Australia for those patients unable to attend the traditional face-to-face group programs. In March 2017, not long after I started here, the GP hybrid program was developed to further expand cardiac rehab service provision and offer collaborative care with the patient's GP. So the GP hybrid / telephone program delivers a cardiac rehab program in collaboration with the patient's GP, offering patients 8 allied health consults, risk factor education, patient support, ongoing reviews, and it's done by combining both the chronic disease GP management plan and team care arrangement and the CACH program. And that's why we call it the GP hybrid program. In terms of eligibility, basically all country patients eligible for an outpatient cardiac rehab program, attending a GP excuse me, clinic involved with the GP hybrid program and are eligible for a GP management plan and team care arrangement can be included in this hybrid model. For the cardiac rehab nurses out there, you were instrumental in developing the cardiac rehab inclusion criteria. The core criteria of those include our ACS patients, patients undergoing PCI stent procedures, people who present with angina, heart failure, and those patients requiring open heart surgery with bypass and valves. There was also an inclusion criteria for strongly recommended conditions such as arrhythmia management, coronary vasospasm, atrial fibrillation, TAVI procedures, coronary slow flow, and structural heart disease. It's quite a busy flow chart here, but it's really just to demonstrate the GP hybrid program process from beginning to end. And I'm just going to show you the following table, which will put it into simpler terms. All right, pardon me. So referrals can be made by any health professional, or the patient can self-refer. Eligible patients are contacted by a CHAP cardiac rehab nurse for enrolment, and in coordination with the general practitioner, the practice nurse is then informed and develops a GP management plan and team care arrangement with their patient. A nursing assessment is conducted by a CHAP cardiac rehab nurse, and the telephone program is done generally over 7 weeks with 3 cardiac rehab nurse calls, 3 allied health calls, followed by a 6 and 12-month review call. The ongoing review is conducted by the GP clinic ideally as a result of the patient's GP management plan, which is renewed every 12 months. These 2 dates don't always marry up though. But by doing so, it ensures that the patient's risk factor targets and clinical outcomes are monitored for the duration of the GP management plan, and potentially for as long as that GP management plan is continually renewed and reviews. So potentially this could be a lifelong thing for the patient, which is kind of the whole point, I suppose. We do use a completion summary here. So enrolment letters stating the patient goals are sent to the patient, their GP and cardiologist at 4 time points. At the commencement of the program, completion of the program, 6-month review and 12-month review. And those all three parties receive the exact same completion summary at those 4 time points. Over these time periods, the patient and their GP and cardiologist can have a snapshot of their cardiac risk factor profile, the trend in results and targets to aim for. So it just gives the patient's journey over the course of the 12 months. These are some results to date. So it's sort of separated in 2 sections. So to date, there are 22 GP clinics in the program. When I did this presentation last year, there were 9.
Oh, wow.
Yeah.
Yeah.
So there's been a massive uptake from GP clinics into the GP hybrid program, and we'll continue.
Oh, look, got a clap on the screen.
And we just continue to build on that every year. And to date, we've got 138 patients referred into the program. Of those patients, 130 have completed. 6 are currently doing the program, and 2 are awaiting enrolment. So we also encounter patients who decline or withdraw from the program, and this might vary from further illness, simply being not interested, wanting to self-manage, and the withdrawal reasons are mainly due to the GP management plan not being activated within the 7-week time frame that the telephone program was conducted. That's sort of just a stipulation of the project. We do have video conferencing capability at some sites, but to date this still remains highly underutilised, unfortunately. All right. So clinical outcomes were evaluated for the group of patients that were enrolled into the GP hybrid program over a 12-month period. So when we did this last year, there were 31 patients. So the evaluation of this program was done last year and reflective of results as of the 31st of January 2019. So all 31 patients had commenced and completed the program, and the outcome data that was collected included their full lipid profile, HbA1c, BMI, cardiac-related hospital readmissions, and medication adherence to aspirin and statin therapy. It was found that these patients were meeting Heart Foundation guidelines, with the exception of BMI pretty much across the board. There were a few hospital readmissions reported at the 6 and 12-month review, but it was noted that there was a decline in adherence to aspirin and statin therapy as time progressed. It must also be noted that the patient sample size available at the time for each parameter was not consistent across the entire 12-month period, and this is mainly due to the availability of data for these patients, as it's a rolling program. So the other things that sort of affected it were patients not picking up their phone at the review calls, despite multiple attempts, and the other issue was patients not doing their bloods as requested. So here are just some numbers when we look at LDL and HDL. So target LDL of less than 1.8 was reached by the 12-month review, although remained elevated at pre-commencement, post-completion and 6-month review, but we eventually got there. Pleasingly, target HDL was achieved at all 4 time points from pre-commencement right through to the 12-month review.
That's good work.
Yeah. Total cholesterol was elevated at pre-commencement, but met target total cholesterol of less than 4 at post-commencement, 6-month review and 12-month review.
Great work.
Target HbA1c of less than 7% was achieved at all 4 time points. However, target BMI of less than 24.9 was not achieved at any time points for the duration of the program. And the cardiac rehab nurses online will probably attest to that, maybe with some of their patients as well. Its weight is it remains a huge long-term issue, is not the word. Challenge. Goals. It's a long-term goal.
I think that's a positive.
We looked at medication adherence. So adherence to medication therapy for statins was highest at pre-commencement, not surprisingly. Unfortunately had a steady decline as the program progressed. Aspirin therapy was also highest at pre-commencement and had a steady decline as the program progressed. But it was noted to have increased to 68% at the 12-month review. So adherence to medicines can be a bit of a challenge as well. So the results of the GP hybrid program at the time that we did the evaluation indicate good adherence to the program once commenced. And it resulted in positive clinical outcomes in achieving risk factor targets and preventing further hospital readmissions. Further attention needs to be considered when evaluating the program in the future. We need to include factors such as their age and clinical diagnosis in order to more accurately decipher discrepancies in the data results. And I noted at the time that it would have been beneficial probably to have done a 9-month review to encourage adherence, and certainly with the CATCH program we are in the throes of a project that's trying to address that issue. Subjective feedback from survey results was positive, with comments highlighting the benefits of the GP hybrid program for both the patient and the GP clinic. The program was able to provide their patients with extra support, resources and expertise from the CATCH team, made up of expert cardiac rehab nurses or cardiac nurses. And the practice nurses felt supported by the CATCH staff and by their GP practice as the program allowed them to work within the Medicare funding framework. Some of the barriers noted by the practice nurses included time constraints within the GP clinic, which hindered their ability to conduct the GP management plan within the desired timeframes. In terms of the implications for practice, our long-term aim is to expand the number of GP clinics involved in the program to widen the GP hybrid network in areas of rural South Australia for ease of access to cardiac rehab services for our country patients, and to establish good working relationships with GPs and practice nurses for the betterment of our patients and their health outcomes overall. Access to the GP hybrid flowchart and CATCH referral forms have been streamlined by uploading digital copies to the country SAPHN website for download. And we'd like to increase the use of video conferencing consults because it does allow the clinician to conduct these visual assessments on their patients, particularly if you're assessing wounds and things like that. I think it can or has the potential to further enhance the patient's cardiac rehab experience and foster a better or just a different rapport between the clinician and the patient. Gaining continued feedback from patients and the practice nurses will allow for the assessment of areas which may need further improvement, in addition to highlighting the successes of the program. So in conclusion, the GP hybrid program provides a transparent, patient-centred program through a collaborative care approach between the cardiac rehab nurse, GP and practice nurse. The CATCH telephone program allows for intensive education and support in those very early stages of recovery for the patient post-procedure, delivered by expert clinicians using evidence-based practice. It encourages goal setting and teaches patients to develop strategies to sustain lifestyle changes, whilst the GP management plan and team care arrangement ensures the long-term management of the patient's cardiovascular disease and other chronic comorbidities, in addition to the ongoing monitoring of their risk factor targets, potentially lifelong. Feedback to date indicates that there is continued interest in the GP hybrid program, and that it is a valuable tool with scope for growth and expansion in the area of telehealth service delivery. Does anyone have any questions?
Any questions, you can either type them into the chat box. Oops, we might end the show. Or you can feel free to unmute yourself. There is something in the chat. We have had a question. How do you measure adherence to medications?
Oh, good question.
Yeah, great question.
Telephone is self-reported, all of it. We were having a chat about this the other day, and we don't feel that patients are pretty honest. You know, we can tell if they're telling porcupines. We sometimes
they're not lying about their weight loss, are they?
Yeah, that's true.
We sometimes, I mean, I can't say we, but I have sometimes double checked it. If they've got a webs pack, I will more often than not contact the chemist and get a list of their most recent, you know, what they've dispensed most recently, and I'll always sort of check that against what the patient has told me. GP summaries you can also use, particularly with the GP hybrid program. That's, you know, fairly up to date. But yes, self-reporting, it's a lot of trust between you and the patient, which you establish fairly quickly and can maintain for the duration of the program.
Can I add to that? We are in the process with the project of hiring a pharmacist who's been sponsored by AstraZeneca specifically to look at adherence. Mm-hmm. So she will be all yours to work with, mm-hmm. to help measure, maybe with data, medication adherence. So that will be their job. So and we'll be getting them to come and sit here at ICCNet mm-hmm. on regular accounts. So we might be able to get some good data while they're here doing their stock. So,
and certainly we've got a clinical pharmacist, part of the CATCH team, who's, you know, part of the 7-week program, and really, you know, Sue's really diligent in making sure, she's very thorough in making sure that, you know, the patients are aware of what medicines they're on and all the interactions and contraindications to things. I know that she has sometimes recommended for home medicines reviews for patients. Have you guys noticed that in your notes? So again, that is in conjunction with GP care. So we do.
Did you look at the Brett Little's business model for GP and hybrid? So we got an accounting firm to do a business model to encourage the GPs to get involved. And the business model says they can make $1,100 per patient by following them along. So hey, that's an incentive, right? And that business model, chronic disease plan care, basically it's quite simple, includes an HMR, home medication review. So that might give us some more information about medication adherence as well. So we've got some really great updates coming along on that to help with that area. So that's good.
And we've got another question here. Great program. What benefits do the GP/PN practice nurse find by being involved?
Do you reckon they'd go?
Yeah, so we actually, that's a great point actually, Claude. We might pause that question from Vanessa, because on the line we should have, I feel like I'm doing talkback radio or something, on the line here in Adelaide, we should have Dr. Ken Wangahu and Judy Sparrow, who, here's something I prepared earlier, who are from Waikerie Medical Centre, and feel free to turn your camera on, guys. Oh, there's Ken. And we invited them along today too. There's Judy. Hi, lovely to see you both. We invited them along because we thought it would be nice to have the other side of this presentation of what Claude's been talking about and people that have the lived experience of this program. And I've given Ken a few speaking points and he's roped Judy in as well. So Ken, do you want to answer Vanessa's question about what benefits do the GP and Judy as well, GP and practice nurse, find by being involved? Over to you guys.
Hi, thanks, Susie. I think I'll just probably go back a step and say, how did we start? How did we get involved in this? And it would be around the 2007 mark that we realized that there was no rehab for any cardiac rehab for our patients once they came back from having their cardiac intervention. That was it, and our patients were, the evidence for rehab is so good. We thought our patients were missing out, so that was an incentive for us. And we then started doing our own. We then got in touch with ICC, ICANN those days, and that's how we then came up with the basics of it and came up with the online model, and from that things just grew. So our main benefit is having a coordinated system that will give our patients cardiac rehab. So that is what we gain. We get the support, so we get equipment, we get, as you heard, the video links. That for us is, it's benefit for our patients and just having a system that works, because without that support we would not be able to it would not be financially viable to run a cardiac rehab system for us. So that big support is really important. So it's patient, but the support makes it viable. I don't know whether that is an appropriate answer at this point. Judy, anything else?
That's fine. And the patient does have support when they get back. They didn't have that before.
Yeah, it's great. Yeah, fantastic. And Ken, do you want to talk to us about perhaps what you see the value of GPs and how they can be part of a patient's long-term heart health for life is our catchphrase in CHAP, and how you can see, does the GP hybrid program help you to get that off the ground and then establish a sort of long-term heart health sort of program of care for these patients?
Yeah, so again, at the risk of sounding corny, I would say, remember that general practice is that birth, labor ward to graveyard care. So this is a really important part of that continuum. So we are just making sure that the GPs are the ones that know the patients, they are involved with them continuously. So when they've had their intervention and they've had their cardiac, they've seen their cardiologist, they've seen their heart specialist, all the different parts that make up the patient's journey, we have the GP standing at the middle, or well, the patient's in the middle. Over it, we have the helicopter view. We bring everything together. So having the GP there is really, really important in that coordinating and directing role. So we know our patients very well. So we know the patients who are not compliant. We know the patients who have the MI because we see them smoking down the street, regardless of what they might what they might say when you call them to talk to them, because we see them every day. And rural general practice is really rich in that way. The data that we have is live and real. So to get the GP involved, I think, is such a fundamental part of any bit, but especially cardiac rehab, because as you know, with cardiac rehab, when the patient comes back, they've had their MI, the metal's hot, they're very easy and very malleable, but that reduces with time. So to have, because they will still come back and see the GP, it just complements that, and they now have a formal system that we can actually follow and make sure that they are doing the steps and they are sticking to what is necessary. And Judy is extremely good at cracking the whip at that. And I must say, having a practice nurse, not the GP does a small part, but a practice nurse who champions it is a really, really important. So wherever you are in your practice or in your region, having a champion that will make sure these things are happening is a very, very important part. And that keeps the GP in line and makes sure the patient is also in line. So Judy.
Yeah, no, well, it works both ways because we get GP support, so we're quite lucky, and we get involvement and support from Rosie and Jan and everybody down at Flinders, so it's really quite helpful, very helpful.
Excellent. And I just called for some more questions. Just had a question from Alini. How is your experience with the video consults? In this case, in your clinic, how do they go?
Yes, thank you. We were going to talk about that definitely. But what we have identified is that it is extremely difficult to coordinate so that everyone is at the right time, at the right place, right time, correctly, and so we can do it. And that's our biggest problem. That coordination seems difficult. And our suggestion, so the coordination to get it happening is difficult, and that's where we fail, and that's why our use of video is not as much. But we do see an opportunity with allied health, especially, and for example, we struggle with a dietitian, and a dietitian health education would work extremely well through video conferencing. So that sort of activity is where we think we would benefit most rather than our standard routine reviews, which we tend to do quickly over the phone and easier over the phone, and we don't have to bring the patient in sometimes. So that coordination. But Judy and I have always thought, especially the dietitian, I don't know what else, would be very useful.
Because we've got there's a community health dietitian that's available for diabetic patients, and they are a priority, whereas if it's diet related for weight loss and things like that and maintenance, they're not high on the list of priority. No matter if they are cardiac related, they don't seem to be able to go up the queue. And there's only one for the whole region, so they're spread very thinly.
Yeah, resources are always difficult.
Yeah.
But that's really interesting. Any questions from in the room? No, just we've got quite an audience here today at ICCnet. The crowd is growing. We do have another question from online. We've got a few more minutes to go, so we'll try and squeeze in a few more questions. Tony says, thanks, it's always very helpful to have GP and cardiologist champions like yourselves. This is not always the case, so do you have any suggestions? Just a small question, guys.
Yeah, I think that, again, it's always the one thing that always works with GPs is that making it clear what their patients will get out of it. All right, that's really, really important, because that's really a big thing. And then minimizing the bureaucracy and the red tape, because we absolutely, all of us, we're human GPs, we hate having to go through 20 different layers to get to that one point. So simplifying it. And then I have suggested before, and I'm sure Claudine would agree, just that case management, so that I have someone that looks after this region. We have a very good relationship with ICCnet. We know who to call if we have a problem with our equipment. We know who to call if we have a suggestion. People talk to us. We are not just out there hanging out around the edges. We feel really part of it and right in the middle. So getting involved, I would say, my simple word is case management, and with us that works really well. So you've got to identify people who are interested, you've got to show them why, and then use your champions to build more champions.
Yeah, very well said. That's great. Any other questions from online or in the room? That's so helpful though. And you've covered all the speaking points I gave you, Ken, organically. So well done. And you roped Judy in as well. Excellent. Well, I'll give another minute or so for questions, but thank you. I hope that's been really helpful to everyone today, just to see another facet of how we can deliver cardiac rehab, how we can work more collaborative across the board, and obviously some champions here in Waikerie that are, great to hear, Ken, that you really feel in the centre of it, and great relationships with ICCnet. The other thing that CHAP study will do, or project will do, is really help to hopefully streamline some of those processes that we talked about. So we'll have one set of electronic assessment forms for all the patients. The GPs will have the same set as the cardiac rehab coordinators. We're just building those as we speak in the background, and that will be part of what you guys have access to. So everyone will be filling in the same data, and as we've said repeatedly, that data will make sure that we cover all the national quality indicators and all the requirements as part of the new standardised program content. We've just had one more question. How do we know which GP clinics are involved? I'm going to throw that one to Claudine.
So Central Referral Office is your, Jodie Thomas, who's the Central Referral Office Manager, will let you know who's in the GP hybrid program, you know, which of the 22 are on there. So you can, do they have our contact number, email?
Don't know.
Oh.
Yeah, feel free to give it out, or we
Yes.
can email it out.
Yes.
Yeah, actually we'll circulate all those details in
Okay.
the email that we flick out.
Okay,
Yep.
so
Yep.
yes, we can provide the group with the contact details for Jodie.
And please improve the referrals.
Yeah.
Yeah, absolutely. You know, we hope to increase the GP clinics by at least 4 a year, and we're managing to do that. But we encompass all areas. You know, we're out Streaky Bay, we are on the Limestone Coast. Where else have we got? Roxby Downs,
Claire. Yeah.
Barossa. Yeah. So, you know, far and wide. The GP clinics involved in this program isn't a cluster. It's really widespread, and that's really what we want to try and achieve. When you think about those poor patients up in, I don't know, I always think CPD and north of that, you know,
Above the line.
Yeah.
very few, very far away from a traditional face-to-face program. So if we can get GP involvement, even better still. Yeah.
Awesome. Tony, over to you.
Yeah, thanks. I thought I'd better talk because I have some questions. It's really good. We're looking at how we do our face-to-face and group, and also we're looking at telehealth of our own with iPads and stuff in the lower southeast. I just wanted to know, I suppose that last question was, because we don't want to duplicate what's going on. We've got limited resources, and we've got large numbers of referrals coming through our way. So I think it's really good to work together, I suppose, which we tried to do, and we tried to do. But yeah, it's good to know what the other parts of the program are doing, so we can then know what to target. You know, we've been asked by one of our local GP clinics to go and have a chat about cardiac rehab, so they're obviously interested in what we're doing. So so I just thought I better.
Yeah, that's great. I'm glad that this session's been helpful. That's great. Yeah. So I guess the other idea with CHAP is that if a patient starts in a program face-to-face, and then this is ultimately what happens, they go back to work, and they get busy, life goes back to a bit more of normality, then they could transfer across. That's the whole idea of CHAP, is to try and increase access and also increase completions by giving them options on how they can complete their cardiac rehab. So they can do that now in the current system as well, but we really hope to streamline that process with CHAP so that they can transfer across to GP hybrid, or they could transfer across to the web, or they could transfer across to just Catch, not just Catch, to the wonderful Catch, or catch yourself, Susie. So that they will, you know, and that's, as we progress this education series and as we roll CHAP out, we'll be making sure that everyone knows that, so that if you have a patient that's like, I don't know if I can come back next week, that you can present them with these options, and that will be coordinated, we think, through the central referral office. So and we'll be letting you know those pathways as we sort of map them out, and as we build our database and sort of do, the database will be Catch version 2.0, which will equal CHAP. So won't be heaps and heaps of change, but hopefully just streamlining and improving and updating.
And that can happen now too.
Yes.
That can happen now too. So that example is if a patient is doing face-to-face and they have to go back to work, you can re-refer back to the Catch telephone program, and it's reciprocated. You know, if we have patients that have been referred to the telephone program and would prefer the group model because they prefer being around other people, then we would refer back to their nearest face-to-face. So it's already in practice. I think this just enhances it even more in those areas where both telephone and face-to-face is available, but also provides that extra in those areas where there is nothing available but telephone. So just put everything back through Central Referral Office, and we will always refer it according to what the patient is requiring.
Awesome. Cool, thanks. Well, it's 1:46 and we always try and do these sessions on time. We did have a bit of a tech disaster at the start, so apologies for that. Thanks to everyone who joined us today, and thanks to our speakers, Claudine, Ken, and a reluctant Judy. Thank you very much for coming online, and thanks for everyone for joining. As per usual, they'll be recorded and we will send out the link, and I'll also send out the information that we've promised in my follow-up email, and eventually that will make it onto the CHAP website as well. But I'll continue the normal process for now while the CHAP website's sort of getting up and running and everyone's making their way around it. But you can get the information there, but I'll also send it out. So thanks everyone. Hope you had a great lunch break and have a great rest of your week.
Thanks,
Bye.
Susie. Thanks, Claude.